All right. I think we are live. Welcome to NMA Talks, where we feature the leading physicians and experts in African American health. This program is specifically designed for the non-medical audience and is brought to you by the National Medical Association, which is the collective voice of African American physicians and the leading force for parity and justice in medicine. I'm your host, Dr. Michael G. Knight. You can find me on Instagram and Facebook at The District Doc. I'm a board-certified internal medicine and obesity medicine physician and assistant professor of medicine here at the George Washington University in Washington, D.C. And we are jumping into the topic of glaucoma and the African American community, a very, very important topic. It is also Glaucoma Awareness Month. We're going to talk a little bit about that, and we have two exciting experts here from the National Medical Association. I'll start with Dr. Nanita Brown, is a glaucoma and cataract surgeon at the Thomas Eye Group in Atlanta, Georgia. She completed a glaucoma fellowship at Duke University, and during her fellowship, she received specialized training in glaucoma treatments and surgery. She is the chair of the NMA ophthalmology section, and locally she is a board member of Prevent Blindness, Georgia, which funds vision screening for children and underserved adult populations throughout Georgia. You can find her on Facebook at NMA Eye. So welcome, Dr. Brown.
Thank you, Dr. Knight.
And then we will have Dr. Daniel Laroche, who is a glaucoma specialist in New York and director of glaucoma services and president of Advanced Eye Care of New York. He is affiliated with New York Eye and Ear Infirmary of Mount Sinai, New York University, and Island Eye Surgical Center. He is a clinical assistant professor of ophthalmology with Icahn School of Medicine at Mount Sinai Medical Center in New York. Dr. Laroche is a nationally recognized ophthalmologist and the former chair of the NMA ophthalmology section. You can find him on Facebook at Advanced Eye Care of New York. So welcome, Dr. Laroche.
Thank you very much, Michael. Pleasure to be here.
All right. So why are we talking about glaucoma tonight? You know, one of the things that we know is glaucoma is a condition that is very prevalent in the United States, but not only is it prevalent, it's prevalent in the African American community. African Americans are up to 5 times more likely to be diagnosed with glaucoma than Caucasians and are 6 times more likely to go blind from it. It remains the leading cause of irreversible blindness among African Americans, and we know that there are challenges not only in the diagnosis, but also the treatment. And the best way, one of the best ways to start to address this issue or to continue to address this issue is to educate the community on the importance of glaucoma screening, but also what is glaucoma? You know, if we don't even know what a condition is, the challenge for us to take it seriously, to ask our doctor about it, to ask when am I going to get my screening is not going to be there. So why don't we jump right into it? And I'm going to start with Dr. Brown. You know, as I stated, glaucoma is the leading cause of blindness among African Americans as well as Latino Americans in the United States. Between the ages of 45 and 64, glaucoma is 15 times more likely to cause blindness in African Americans. What causes the development of glaucoma, and why are African Americans so heavily affected?
So the number one risk factor for glaucoma is elevated eye pressure. And so we have a lot of patients that have never had their eye pressure checked. They don't even know where they sit in this risk factor. So that's one of the main things that needs to happen for all populations. Specifically for African American and Latino populations, the biggest risk factor is that the cornea, which is the very front of your eye, is very, very thin in underrepresented minorities, Latinos, Black patients. So kind of like if I had a balloon versus a basketball. If I increase the pressure in a basketball, it's not going to be damaged. It's going to keep its shape. But when I have a thin shape like a balloon, when the pressure goes up, you get damage to the balloon. So that's one of our risk factors, which runs in families and runs in certain populations.
Thank you. Thank you for outlining that. Dr. Laroche, you know, health disparities and caused by financial inequality with decreased access to medical care, medications, and surgical treatment. This income disparities, health insurance disparities, does that contribute to some of the reasons why we see such a disparity in the African American community?
Absolutely. I mean, one of the biggest disparities in glaucoma is the rates of blindness that several times higher in blacks compared to whites. And that's also directly related to the financial and wealth inequalities in the community. The average white family, the net worth is about $171,000. Average net worth of a black family is about $17,000. That's a tenfold difference. The differences in access to care, access to health insurance, access to medications, access to surgery. So based on the wealth disparities alone, that's a huge factor. Then we have a shortage of black physicians. Only about 2% of ophthalmologists are African American. About 26,000 in the United States and only about 400 African American. And African American communities, we don't have access to black ophthalmologists. So lack of access to care, lack of education in that respect is a big issue. To address this, there's a lot of potential solutions that are out there. Increasing the minimum wage to $15 an hour, that provides people a living wage so they can work their way out of poverty. For those people that are unemployed, have some sort of a basic income, maybe $7 an hour or $7, per hour for a day if you're unemployed. So at least you could work your way out of poverty. But this poverty and wealth gap is huge and contributing to that. And we need to train a more diverse workforce so that we can have more doctors in the community and increase access to care to patients in the community. Because unfortunately, we still have a lot of segregation. If you look at any community across America, if you look at one side of the railroad tracks to the other, there's still a lot of segregation. And so that's why we need more black doctors.
Thank you for that. Thank you for that. Let's jump back a little bit to understanding just what glaucoma is. And we have a very short video clip that we're going to get some of the basics. We want you to be able to visualize it, because I think when a lot of us think of our eye, even remembering the anatomy of it, I know many of us in medical school, it took us quite a minute to understand that. So for the average person, I'm sure, just understanding where is this pressure, where is fluid in my eye? Why don't we take a look at this video very quickly?
Glaucoma is a leading cause of blindness, globally affecting nearly 80 million people by 2020. This silent thief of sight involves optic nerve damage and visual field loss secondary to retinal ganglion cell damage or cell death. The eye produces fluid from the ciliary processes to bathe the eye. The fluid drains via the trabecular meshwork, aqueous veins, uveoscleral pathway, and suprachoroidal space. With time, the trabecular meshwork ages and the lens of the eye becomes larger, developing a cataract. This narrows the drainage angle, reducing the ability of aqueous to drain from the eye. Additionally, in some patients, the zonules that attach the lens to the iris rub against the posterior iris, releasing pigment that further blocks the outflow pathway. This, in addition to genetic predisposition in some patients, leads to elevated intraocular pressure. This increased pressure goes on to damage the optic nerve, described as cupping. When this occurs, medical therapy should be initiated. Since as many as 50% of patients fail medical eye drop therapy, early cataract extraction can be performed to open the angle, and goniotomy should be performed to remove the damaged trabecular meshwork to help improve aqueous flow. Patients with advanced glaucoma due to worsening outflow will need an additional intervention. Dr. Daniel Laroche is a board-certified ophthalmologist and glaucoma specialist.
All right. So I hope that you were able to get at least a visual idea of the eye. So the biggest question that's going to come up for patients, Dr. Brown, is will I go blind from glaucoma? I've gone to the eye specialist. They've told me that maybe there is glaucoma suspect, for example, that we've heard that term. The eye pressure may be going up. Am I definitely going to go blind from a glaucoma diagnosis?
No. The reason people go blind is because they don't follow up and they don't get treated. So that is the number one priority, is the diagnosis and the treatment.
And when we talk about diagnosis, Dr. Laroche, what will let somebody know that they may be suffering from glaucoma or on the path to glaucoma? Is there a symptom or is there something distinct that patients can look out for?
Now, that's a great question. Glaucoma is a silent thief of sight. You don't feel it, and it slowly takes your peripheral vision away first, slowly, very slowly, very slowly. And then by the time you notice it, you've probably lost 80 to 90% of your vision in one eye. A crude test you can do is cover one eye and look at a credit card. Can you see the credit card okay? And cover the other eye and see the credit card. If you notice a big difference between light and dark within one eye you can't see, then make sure you get your eyes checked out to find out what's going on. Is it just a pair of glasses? Is there something else going on? You have retinopathy or glaucoma or cataract. That's a crude test you can do to check on that. And then everyone over the age of 40 should get the eyes checked once a year to check their vision, check for cataracts, retinopathy, and check for glaucoma, know their eye pressure.
You know, what you said was so important. So you're saying that, by the time I may realize if I'm not having vision screening, I may have lost such a significant portion of my vision. So Dr. Brown, if I do this test that Dr. Laroche said, I've now looked at the credit card, something's a little off, can I walk into an ophthalmologist's office? Can I go to an optometrist where I get my glasses, for example? Should I talk to my primary care? What should I do next?
The first thing I would do is try to make an appointment with either your primary care doctor or with the optometrist. Usually the optometrists are very good at screening patients and sending them on to us. Our primary role is as surgeons. So usually the optometrist can begin treatment if you need any kind of drops, but it's always a good idea to get a second opinion. So here in Atlanta, I'm with the Thomas Eye Group. We have a lot of offices. We have 10 offices throughout Atlanta. And so the best thing to do is just to get a screening exam, especially if you're over 40. Just have somebody check your pressure and figure out where you fall in the risk. Have somebody check to see how thick your cornea is, especially if you have a family history of glaucoma. We have a lot of free services through the American Academy of Ophthalmology. There's iSmart, which are doctors who can give free care. So by calling our offices, you can get screenings. The Lighthouse also provides screenings throughout the United States.
Mm-hmm. And we see here a question from someone in the audience really asking about if someone does not have insurance, are there ways to get eye screenings? I know it's going to be different from state to state, but why don't you, Dr. Laroche, tell us what it's like in New York? If a patient is uninsured, are they able to get screening for glaucoma?
Well, yeah, I mean, if you're uninsured, there are safety programs we have in New York with the Medicaid program. So you can get some basic health insurance if you cannot afford to purchase health insurance, and that will be able to get you into the healthcare system. Because the thing is, it's not just about getting screened, because what if you're screened and you're positive for retinopathy or for glaucoma? You're going to need treatment. Mm-hmm. So you got to have a more definitive pathway. Also, if you go to the local hospital and you go to the social work department, they can let you know what programs and opportunities are available depending on what state or county that you're in. That can vary, but usually our country's pretty good about getting people the care that they need.
Mm-hmm. And of course, we know about many federally qualified health centers, and those are community health centers that usually will see patients even without insurance, and usually on a sliding scale based on income. So that is also an opportunity for patients who are uninsured. I see another question from the audience. I'm going to be putting some of my questions in, but please put your questions in the comment box. We're going to get them in the program. So we have one from Will, talking about a 15-year-old son who is diagnosed with likely early onset glaucoma. They're going to see a specialist. How worried should we be? And I think this question goes to a larger question of who actually gets glaucoma. We talked about over 40. So do you see glaucoma in younger patients? It seems here like this is an example of a younger patient who may be having some increased eye pressure. And Dr. Brown, why don't you take that?
Definitely. So there is congenital glaucoma. There is juvenile glaucoma. The most important thing is to have somebody that you can see and that you trust to examine your son and to follow him. Glaucoma is a very slow disease if we're able to lower the eye pressure. If it was my child, I probably would at some point take him to a university-based hospital and have him see a pediatric ophthalmologist or a pediatric/glaucoma specialist. We have that here at Emory. So I send a lot of patients and share a lot of patients that are younger with pediatric ophthalmologists.
Thank you for that answer. We have another question. I'll send this to Dr. Laroche. Is there a registry for African American or Latino glaucoma specialists?
That's a good question. Just before this program started, I was just talking to Dr. Brown that we have to set this up. So officially not as of yet. I've been wanting to do that for a while, got a little pushback, but we're going to try to do something. And it will be on the NMA, National Medical Association Ophthalmology website. And you can email us because we know doctors around the country. So if you email either of us, we could probably connect you with somebody until that registry is up.
All right, so let's jump back. I see some more questions coming in, and I'm going to use this question to take us to the next part of the conversation, and we'll send this to you, Dr. Brown. So there's a question about what medications can cause or worsen glaucoma, and I want you to answer that and kind of touch on what causes glaucoma outside of genetics. So are there things that people do? Is it, or things that we're eating, our activity? Can you talk a little bit about that and include medication?
So my overall advice to all of my glaucoma patients is if your overall health is good, that helps your eye health. So if you are exercising, having a balanced diet, just taking care of yourself in general, that's going to help your eye health. So there's no supplements or anything that we know that can treat glaucoma outside of the medications that we prescribe. In terms of drugs that may put you at higher risk, any exposure to steroids. So if you've had steroid injections or if you're chronically on steroids, that can change the outflow of your eyes. So it increases the pressure. So we have a steroid-induced glaucoma. There's also glaucoma that can, you see on all the warnings on a lot of your different medications, beware if you have glaucoma. So some medications can actually close the drainage system of your eye and send you into a high pressure, which is an acute angle closure of glaucoma. So those are kind of the large categories of things that can acutely change the dynamics and the anatomy of the drainage system of your eye and cause the pressure to go up.
Okay, thank you for that. I did see a question come in about supplements, and you mentioned that we really haven't seen the evidence for some of the natural supplements, particularly in glaucoma. Now, I think that this is with supplements in general, because everyone may say, I know someone who it helped, and then somebody who didn't help. So we're not what we're seeing is that the evidence so far does not support you not going to the eye doctor or not considering some of these treatments and only doing that. I think when we talk about lifestyle interventions and natural remedies, it's not an either or, right? We want to make sure that the natural remedy isn't making things worse, but oftentimes just talk to your ophthalmologist about it. I'm sure you, Dr. Laroche, if a patient comes in and says, I want to do everything you're telling me, Dr. Laroche, but I also heard about XYZ. How do you interact with patients who may want to add supplements to their treatment plan?
Well, supplements I usually reserve for people who are not able to eat properly, have a poor diet, have poor access to food in that respect. So I think the best medicine is healthy food, lots of salads, lots of vegetables, baked chicken, baked fish. Those types of things are the best nutrients that you can get into your body, and it's natural. Now, some of our elderly patients have other issues where they can't access those types of things. And then I may recommend some additional supplements. I see a question about miterginol, whether that's an effective supplement. I find the most effective thing for treating adult glaucoma is early cataract surgery and angle surgery to restore the outflow. My algorithm has changed. The current standard of care is using eye drops and laser. But we both know from years of studies that with eye drops and with laser, glaucoma continues to progress. Okay, when I do early cataract surgery and open up the drain, I'm really able to get people off of medications, get their pressure down, and really sometimes completely stop their glaucoma in many cases. The earlier I can do that, the better. And then I'll use eye drops. I find that eye drops, if needed thereafter, are far more effective than supplements. Okay, and I'll use eye drops and or laser if needed thereafter. And then supplements, like I said, depending on the diet of the person.
Thank you so much for that. We have another question coming in. And so here's Sahai. Welcome, Sahai. She's followed us on NMA Talks before. So talking about, having a mother who is being treated for early stage glaucoma, it's a long-term process that requires ongoing treatment. The question that I would jump off of this comment, and thank you for sharing your experience, is, Dr. Brown, can you cure glaucoma? Is this a chronic disease? If I'm diagnosed, we talk about treatments to slow the progression, but can I be cured?
At this stage, we don't have a cure for glaucoma. I think in the future, when we start developing new technologies, different gene treatments, I think that there will be a cure for glaucoma. But at this point, we can slow the progression with surgery, with medications, with lasers. There is a disparity right now of people who are getting surgery. So African Americans and Latinos are less likely to get surgery. So it's really important that you get the diagnosis and that you're able to be seen and that we can slow the progression.
Thank you. Thank you. We have so many more questions coming in. Keep those questions coming for our specialists. Are there ever any unknown or atypical reasons why one would develop glaucoma? Dr. Laroche, so are there typical reasons, or, can it just be unknown? Do we always have an answer to what has caused the glaucoma?
Usually there's a reason behind it. If someone has glaucoma and I look carefully enough at their eye, I can find out something that happened. An example is if someone's had trauma to the eye. Let's say you were playing a sport, you got hit really hard in the eye a few years ago, and you didn't remember it. And then you develop glaucoma in that eye because you had damage to the drain. Usually when I examine the eye, I'll see some evidence of trauma. That's one. If someone has untreated diabetic retinopathy for years, and then all of a sudden they come in with sudden loss of vision, high pressure, eye pain, and I'm looking at that, I say, okay, that retinopathy. We call those secondary causes of glaucoma. Okay. And once again, that's why it's important to get an eye exam, because sometimes we can pick up these things a lot earlier. And I just want to follow up on something Dr. Brown said, where is there a cure for glaucoma not being a cure? But we can't prevent glaucoma. In my practice, one of the largest causes of glaucoma is the enlarged lens in the eye. And so when that pressure starts to creep up, and if we can act on that earlier on and open up the drainage angle, prevent angle closure, studies have shown that with increased cataract surgery going up, the prevalence of angle closure goes down. So we can prevent glaucoma with earlier surgical intervention in the appropriate patient.
All right, Dr. Brown, we have another question that's come in. There was a question that's saying, I was diagnosed with Fuchs dystrophy. I might increase risk for developing glaucoma. So you're going to have to tell me what that is. The little internist here. So go ahead.
So Fuchs dystrophy is a disorder of the cornea. It's when the cells on the inside of the cornea become kind of metamorphic. They kind of change shape. And so over time, you can develop swelling of the cornea. Fuchs dystrophy is not a risk factor for glaucoma, but the difficulty with Fuchs dystrophy is if you do have a lot of swelling, it can be difficult to know what your eye pressure is. So those people need to be followed to make sure that there's no damage to the nerve or no changes over time.
Excellent, excellent. So keep those questions coming in, folks. I'm going to jump back a little bit, and I'll give this one to Dr. Laroche. You went into nutrition and glaucoma a little bit. Can you clarify, have we seen studies that nutrition is a large factor in either preventing or treating glaucoma? Tell us a little bit more about that.
Yeah, studies have shown, like some of the Framingham studies, a large studies looking at thousands of people. When you eat a high salad, high vegetable diet, those people have a lower risk of developing glaucoma. So that's pretty well known. Same thing with exercise. Increasing exercise 30 to 60 minutes a day, you have a lower risk of developing glaucoma. Meditation as well. Those people that meditate, do yoga, relaxation, they have lower eye pressures, and that can lower your eye pressure, reduce stressful environment. So the things that you do in your environment can have a tremendous impact, not just on glaucoma, but your whole body as a whole, with lower blood pressure and a healthier lifestyle. So those are all very, very important.
Mm-hmm.
Also the cortisol levels, because that is a steroid. So it can actually, high cortisol levels, that can actually change the trabecular meshwork, just like as if you were taking steroids.
Mm-hmm. So when we think about high cortisol, stress, right? So stress and what we know, unfortunately, is that many communities, many marginalized communities are in a state of chronic stress. When we think about wealth inequalities and racial inequalities and flat out racism many times, where we can see these kind of effects really affecting the health of the patient in general. Another question that we have gotten is the difference between open angle, closed angle. Give us the angle on this, Dr. Brown. What do those terms mean? And tell us why they're important.
So the front of the eye, kind of like the picture we're showing, there's fluid that's being made, and it has to make its way out of that little area. And we call this the angle. So there's a drain right here. So your eyeball is really a ball, like it can pop. So there's fluid being made to kind of keep its shape. And what happens is sometimes it's open, right? So I can see it when I examine it. I know that it's open. I know that it's not blocked off. So that would be an open angle glaucoma, because in essence, there's nothing blocking it. A closed angle glaucoma is where I can't really see that angle, or there's scarring to that angle, or something is pushing it forward like the cataract, or something is scarring it closed like neovascular glaucoma, or trauma or something like that. You would see a change in that angle.
Thank you for that. I know we have another question coming in, and obviously we're not going to give specific medical advice, so we want to give that disclaimer. We do want you to speak with your healthcare professional, but in this example here, we see that there was a shunt put in, but the pressure is still elevated. The problem appears to be my eye scarring. This also occurred with my trabeculectomy. Do African Americans respond well to these operations? And he's talking about some drops that he's on. So Dr. Laroche, can you talk generally about the kind of treatment, maybe surgical treatment options, shunts that may be in place? And do we see any difference in effectiveness for African Americans?
Yes. African Americans don't do as well with surgery, and a part of that is because they present much later with disease. Okay. So if you're presenting much later with disease, a much more advanced disease, the chance of success is not going to be as good. And also, usually this surgery's been delayed. Perhaps they've been on eye drops for many years that has damaged their conjunctiva and makes it scar much more in that respect. That's why my surgical algorithm has evolved to earlier surgery, with earlier cataract surgery and a trabecular bypass, because once you've done that, you can usually lower the eye pressure by about 5 to 7 points. And half of my patients won't even need medications. It can be washed off medications. Now, some of those patients are going to fail. And so then the next step will be what's called a trabeculectomy, where it's a surgery. It takes about 20, 30 minutes. We create a small scleral flap in the eye, okay, to create a little opening for the fluid to come out, okay? And that works really well to lower the pressure, but that can fail over several years. It can have side effects where people see a little bubble on their eye. They feel a little foreign body sensation. There is a lifelong risk of infection that can occur. And then if it fails, despite medical therapy, then there are larger tube shunt implants. The gentleman mentioned the Ahmed valve, there's a Barville valve, Molteno. There's different types of valves that can be used as well to lower the pressure. And those will work for a period of years, but then sometimes they can fail because your eye recognizes that there's fluid coming out, and it's not supposed to be that way, and so it scars down. So your body's naturally responding to this external device and or fluid coming out of the eye. So it's a constant battle in that respect. But the key is to try to prevent it from getting that far with earlier surgery and earlier intervention. The earlier the intervention, the better. Once you get to that late stage where the drain is like 90% damage, it's really hard to overcome and fight that.
Thank you. So go ahead. Go ahead, Dr. Brown.
We also have some new treatments. We have some laser treatments that we can do to lower the eye pressure. And we also have a new injectable medication that we can give to patients who can't tolerate or can't put drops in regularly. So glaucoma is very hot now. We have a lot of new stuff. So definitely take advantage of this time and this opportunity to be treated early and to kind of stay away from these major surgeries that have a lot of complications.
Mm-hmm, mm-hmm. All right, so Dr. Brown, I'll have you take this one. How often should someone with type 1 diabetes who's African American be tested for glaucoma and have a diabetic retinal study?
So usually any patient with diabetes should have an annual exam. And once diagnosed with any kind of diabetic retinopathy, they should be seen at least every 3 to 6 months. And in those appointments, they'll be checking your eye pressure and they can look at your nerve to see if there's any changes. We share a lot of patients with our retina colleagues. So we're very comfortable with patients who have diabetes and being able to diagnose them and treat them. But just like any of these eye exams, eye diseases, the earlier the better, because we don't want to be at the end trying to put a Band-Aid on something that's already causing significant blindness and change to your vision.
Mm-hmm. So we have another question, and I'll have Dr. Laroche take this. We're still in the COVID-19 pandemic, and we've heard about COVID-19 affecting the heart, affecting obviously the lungs, our taste receptors, our smell receptors. Have there been any evidence or any early evidence suggesting any link between COVID and glaucoma, or how is treatment impacted for individuals who have been COVID positive but suffer from ongoing issues that impact their vision?
There's no direct link between COVID and glaucoma that I'm aware of. However, the COVID pandemic has really impacted the community in terms of accessing eye care. In New York, we had a shutdown for 3 months where patients could not really go to their eye doctors. And sometimes, so that delays screening, that can delay treatment. There was a 3-month delay in surgery. People that needed surgery could only go for an emergency basis if you needed surgery. Mm-hmm. And even now, I factor that in when I'm making a decision for a patient that needs surgery for glaucoma. If they're in an older high-risk category, I have to make a determination, well, how urgent is it now? Because our numbers in New York are starting to get higher. Let me postpone it for a few months, maybe when the COVID numbers are lower. And COVID has affected my glaucoma management in that way. And also in our office, we've had to develop new COVID-19 protocols where we have a questionnaire that people have to answer. We check their temperature. We space our patients 6 feet apart to make sure that they're safe and so they can still get the treatment that they need, still get their medications, still get their screening. So we will all wear masks, and we have hand sanitizer throughout the office. So, and even at the hospital, anyone who's going to have surgery has to have a COVID test done before surgery. So we have tremendous protocols that have taken place to allow us to continue to provide care for glaucoma patients. So you should still be able to access your doctor for routine care, screening, despite the pandemic, because all doctors are implementing these COVID protocols. And so if you do that, you should still make sure you take care of your health, because there's a lot of unnecessary blindness that can occur, and unnecessarily heart attack, unnecessarily morbidity and different health conditions, because people are just not taking care of themselves because they're scared to go out because of the pandemic.
Mm-hmm. So important. And what we know, and across the gamut, as you've outlined, there's been a lot of delays in care when it comes to this year because of the pandemic. So we want people to get in and see their doctors, want people to get their follow-up. One of the things that we know with any kind of chronic disease, it has to be managed. And so that is very important. We have another question here from Mr. Cummings. All right. What treatments are available for those who have glaucoma with normal or low pressure? So Dr. Brown, you talked a little bit about some therapies. You talked about laser therapies. You talked about, a new injectable. Obviously, people know about individuals who take drops. When we think about someone with early glaucoma or someone who has lower pressures, what kind of treatment options are we thinking about?
Honestly, the treatment options are pretty much the same. A 30% reduction in pressure, regardless of whether you have normal tension glaucoma or low tension glaucoma. And the problem with everything being based on the pressure is that 2/3 of patients don't have elevated pressure and still go on to have glaucoma. But it's the same treatment regimen. We have surgeries, we have lasers, we have medications to try and lower the pressure.
So what you're saying is just because I've been diagnosed with glaucoma and they say I have normal pressure or low pressure, this does not mean that I shouldn't be discussing other advanced therapies that could be appropriate. I mean, as we've talked about, there may be many patients who just feel like they've been taking drops for years and have never even had a discussion about advanced therapies.
Yeah, I think glaucoma has very much changed. And so we have a lot more things that we can do. We have a lot more treatments that are not involving tubes and trabs. We have the smallest device that you can put in the body is actually a little shunt that you can put into the drainage system of the eye. And so it's brilliant. So it's new and it's brilliant.
Before we go to the next question, Dr. Laroche, because I think this is important. Medicine is always changing. And depending on the provider, the physician's practice patterns, is it academic, non-academic, private practice, where you trained, if someone feels that they may not be getting the optimal care, all right, maybe they've been on drops for years, their vision is getting worse, they haven't been offered any additional options. What would you say to a patient like that to help empower them to talk with their eye ophthalmologist or their primary care and say, I don't know if I'm getting the best care, and not want to be, confrontational. I think sometimes patients are afraid about that. You're not second guessing someone, particularly someone who may have been caring for you for many years. But after listening to this tonight, I may say, all I've been getting is drops. And they're talking about lasers. They talk about, surgery. I haven't heard of any of this. So Dr. Laroche, what do you say to a patient like that?
Well, there are some ophthalmologists that don't operate. And their only option is to give drops or maybe do laser. And they don't do surgery. So a significant percentage of people in our profession will not offer patients glaucoma surgery or certain types of surgeries because they just don't do it. Not all ophthalmologists operate. So if you feel you're not comfortable, if you feel that you're not stable, if you feel that you're not doing as well, there's nothing wrong with getting a second opinion. You can talk to friends and family members, see what their experiences have been. If they know somebody within the community, talk to your primary care doctor. You can do a search online, look for experts in your area, and you can get a second or third opinion until you find someone you're comfortable with, because the doctor-patient relationship is exactly a relationship, where you have to trust each other. Like, you have to trust the advice I'm going to give you, and you're going to take the medications and what I recommended. And I have to trust that you're going to follow that. Because if I feel that you're not following what I'm recommending and you're going off somewhere else, then I don't feel that I'm helping you. And I'm like, okay, maybe I'll send you to someone else or see the other person that you were seeing, because it's a relationship. And then hopefully with that relationship that you feel good with the doctors, and you'll be able to be compliant and be able to be stable in your situation. And then also you can find a group of like-minded doctors. Like, there's a group of doctors in my circle that I work with that are internists, urologists, GI, all kinds of different specialties as well, that, take or as attentive to the patient as I am, and that I trust and I would go to, and I share those contacts with my patients as well.
Yeah, so and we saw a comment on empowering patients, and like you said, it's a relationship. Sometimes you got to break up, and sometimes you got to see what else is out there. So again, we want to encourage people. I think continuity of care is so important, and having a long-standing relationship is important with your physician, but also being educated and empowered, and then understanding if we need to get a second opinion, that's also on the table. Let's bring back that question about autoimmune disease. So. Dr. Brown, are there any autoimmune diseases that are associated with glaucoma?
So the problem with the autoimmune diseases such as sarcoid or rheumatoid arthritis, they can cause inflammation in the eye. And when you have that inflammation, it's called uveitis. And the cells can actually block the drainage system of your eye. So when you have chronic inflammation going on in other parts of your body, in your joints, in your lungs, your heart, it can also be going on in your eye. And over time, the drain can get blocked and cause the pressure to increase. So we do have a uveitic glaucoma, which kind of is all of those diseases. And sometimes patients who have autoimmune disease, they get put on steroids. So that can be the etiology of their glaucoma.
And speaking of steroids, I see another question just coming in. Let's pull that on the screen from Dr. Ayala. Speaking of as a pulmonologist, prescribing inhaled steroids or systemic steroids, how concerned do I need to be in patients with glaucoma needing these medications? Dr. Laroche, so, for our healthcare professionals who are on the line and prescribe steroids, if we have someone on long-standing steroids, should we be ensuring that they see an ophthalmologist? What should we be doing?
Yeah, if you're going to have someone on chronic steroids, then yes, you should refer them to ophthalmologist to have their eye pressure checked to just make sure that they're not developing glaucoma for that period of time. The good news is that the type of steroids that really contribute to the glaucoma is topical steroids. Topical steroids are very powerful in the eye, and you can develop like a high pressure within using topical steroids in about 10 to 30 days. But the systemic steroids is going to take a little bit longer for that. And then one more point I did want to come back on. Someone asked about low pressure glaucoma. One of the things that can cause low pressure glaucoma that I'll check is blood pressure. A lot of times people will have a low blood pressure because they're taking too much blood pressure medication. If they're taking too much blood pressure medication and their blood pressure is very low, that will also contribute to low eye pressure and worsening of glaucoma. So anyone that has a low pressure glaucoma, I always do a 24-hour blood pressure monitoring to see if they're having any low dips at night in particular. And sometimes we have to raise that blood pressure up by having them drink like some tomato juice or a can of soda at night to raise that blood pressure up and get them off some of the blood pressure medication in that respect.
All right, so we're getting some more advanced questions coming in. It looks like our healthcare professional audience has grown. I'm going to throw this to you, Dr. Brown. Do you find yourself utilizing SLT as a primary treatment, and do you use medication alternatives like implantable Durista? And you can let us know what SLT is and give us some of this information.
Yes and yes to both of those questions. So SLT is selective laser trabeculoplasty. So it is a laser to the drainage system of your eye. And the idea is that we stimulate the cells that are in the drain to kind of clear away all of the trash and open up the drain. You can repeat it every 2 to 3 years. It's about 90% effective in a lot of patients. Durista is the implantable medication that I was talking about earlier. We can do it in the office. Both of these procedures we can do in the office to lower the eye pressure. And I definitely do both of them and have had good results.
Now, I want to jump in on this, Michael.
All right, go ahead.
I used to do that, but I don't do that anymore. Okay? I don't do SLT anymore. What I do first is I offer early cataract surgery and trabecular bypass, where we open up that drain that's blocked. She's treating it with cells, treating it with the laser, stimulating it, right? I'm opening it up and putting a stent in to bypass it, okay? And I find that's far superior, far more effective. But the only problem is a lot of patients are shy to have surgery. because it is surgery. And so then you have to maybe resort back to the medications and laser. But all the studies show that on medications and with laser, that glaucoma will still progress over time. Even Anita said herself, Dr. Brown said herself, you have to repeat it in a year or two.
Yes, that's true. That's great.
Good. So many options, so many options. So that's why it's important to talk about the options, know what may be best for you, and have a physician who's on your side. I see another question here about imaging, MRI or CT. Are there any imaging studies that would be a part of the diagnosis or treatment for glaucoma? And Dr. Laroche, you can take that one.
Oh, yes, absolutely. When a patient comes in, we evaluate them. We take the full history, check their vision, check their eye pressure, check the drainage angle, and then we'll do some imaging tests. We'll take a picture of the optic nerve. And so that's a picture that we can see if there's damage to the nerve or not. We'll do a test called an OCT, optical coherence tomography, that actually measures the nerve tissue inside the eye to tell you whether it's normal or if there's thinner, the nerve fiber layer, indicating early glaucoma. And then we'll do another test, a visual field test that checks your peripheral vision. You know, do you have a full peripheral vision in each eye, or do you have some losses or patches there? So those are the type of imaging tests we do specifically for glaucoma in the eye. Not CAT scans or MRI. That's a little bit rarer, like someone has maybe a pituitary tumor or something like that that's unusual. That's part of the eye workup. But anyone who goes in for glaucoma evaluation, you will be getting these types of tests and imaging done.
All right. So we have another question coming in. All right. You guys are hitting us with the questions. And it's talking about, claims that people can cure glaucoma. I know we've said already we don't have a cure. Dr. Brown, are there experimental treatments that may be curative, or where are we on this? Is it that we don't have a cure now, but one may be on the way, or are we a little bit further away than that?
Well, I always tell my patients that the eye is really an extension of the brain. So when you damage the brain, it's very hard to regenerate that tissue. So if we get to the point where we can do brain regeneration in the central nervous system, then we may be able to bring back some of these cells with gene therapy to regenerate the nerve tissue. There are a lot of devices that are available for patients that have retinal damage, but we don't have a device yet for glaucoma because the nerve being damaged is very difficult to get that nerve tissue back to be able to send the message to the brain to let it know what it's seeing.
Well, thank you on that. So we're hoping, but like we said, we don't have any alternative medicine or specific procedures right now that have been proven to be curative. We talked about the prevalence, for example, in the African American community. Dr. Laroche, are there other ethnicities or parts of the world where glaucoma is more prevalent, and not just thinking about black and white, but what other communities should be concerned about this?
Well, I mean, unfortunately, it sort of comes down to black and white for the most part, Afro-Latino communities, because these are the communities, if you're in the United States of America, in the Caribbean, Latin America, Africa, all had colonialism, segregation based on race. And that created a huge wealth gap and access to care gap. And I've traveled to all of these places and I've seen the same thing: delayed disease, lack of access to treatment, and the main thing, and lack of resources to afford medications, to afford lasers. So that's why when I've gone to these places, we try to train with earlier surgery, earlier cataract surgery and trabecular bypass surgery, because that will really help solve that problem in that particular respects. The Hispanic communities, the same thing though, like the darker brown Hispanics, because of darker brown iris and pigment obstruction compared to white Hispanics, they have a higher prevalence as well. And also they have that socioeconomic difference and gap as well. So that's what I've seen. Now in the Soviet Union and Scandinavian countries, there is a type of glaucoma called pseudoexfoliation, where you have a fibrillar material that blocks a drain, which is a different type of glaucoma that has a certain prevalence in those parts of the world. It's also are found in Ethiopia. Okay, a high concentration in Ethiopia as well. So that's a different type of glaucoma that's found. In China, in Asia, they have a higher prevalence of angle closure glaucoma. Okay, much greater prevalence of angle closure glaucoma compared to open angle here in the United States. So there are differences in some ethnicities and some groups with different types of glaucoma that can occur as well.
Perfect, perfect. So we are coming to the close of our program. If anyone has any burning questions, please put them in right now. But I want to close by just having some take-home points. You know, we've gone through so much information. You know, if you just tuned in, and I'll give both of you, you could say one or two things. Dr. Brown, if someone just tuned in, what are the top, 2 or 3 things that you want people to remember from this program?
Get an eye exam. Go and see somebody. I'm on Facebook, and all of my friends, over 40 are complaining about their eyes. Just go see someone. It's better to know if you have anything, especially if glaucoma runs in your family. I would definitely get an eye exam and ask questions. Those are my 2 takeaways. Go see somebody and ask questions.
And just to clarify on that, so everyone over the age of 40 should have had an eye exam. Is that correct?
Definitely.
Okay. And then if it runs in your family, obviously if you're having visual changes, but we don't want to wait to that, or if you are in a conditions, autoimmune disease, or on medications, then please talk to your doctor and say, Doc, do I need to have an eye exam? That I would add to that. Perfect. Dr. Laroche, what do you think? What are some of the top 2 things you want people to remember after the program tonight?
Well, January is Glaucoma Awareness Month, and we've done an excellent job covering this topic. So you want to make sure you get your eyes checked for glaucoma. The other thing I want people to know is that we can prevent glaucoma if you catch it early enough. Catch high pressure early enough with earlier surgery, earlier cataract surgery, trabecular bypass surgery, which is a very safe surgery. It takes about 10-15 minutes. And so take that into consideration for you or your family members that may have glaucoma. And the other thing is the eye is connected to the body. So make sure in addition to getting your eye exam, just get, a good internal medicine exam, family practice exam, get your urology exam, your GYN exam, take care of all the parts of your body, because there's a lot of things that we can do now to really prolong life and take care of ourselves and make sure that our families live a long, healthy life.
Perfect. And so you hear that our bodies are all interconnected. So we want to make sure that we're taking care of our whole body, not just putting one out there. So I know we're coming to the close of our program. We're going to try to look through the comments. If we didn't get to your question, we'll try to jump in and answer that question. We see the contact information for Dr. Laroche and Dr. Brown. Again, we want to thank you all for joining us for NMA Talks, brought to you by the National Medical Association. A special thank you again to our guests from the NMA Ophthalmology section, Dr. Brown and Dr. Laroche. Please check them out. Follow and connect with us at National Med, ASSN, National Medical Association. You can also email us at nmatalks@gmail.com with questions and comments. Be sure to join us next time. We want to bring you information that's pertinent to the African American community from leaders in African American health. Have a good night and take care.
Thank you.
Thank you.